She came in wearing lipstick and carrying a crossword puzzle book. 76 years old, retired school teacher, walked 2 miles every morning, tended her garden every afternoon, and hadn't spent a single night in a hospital since she gave birth to her youngest child 43 years ago. She didn't come in because something was wrong. She came in because her daughter had been nagging her. Mom, just go. Just get a checkup. It's routine. So she went. 11 months later, I saw her again. She was in a wheelchair. She had lost 20 pounds. She wasn't doing crosswords anymore because the medication affecting her concentration made it too frustrating to focus. Nothing had been wrong with her when she walked into that office, but something had been found. And once something is found, medicine moves. It doesn't pause. It doesn't ask whether you'd rather just live your life. It moves. My name is Dr. Ava Wilson. I've spent my career studying what the evidence actually says about health and aging, not what the system assumes, not what the checklist demands, but what the research genuinely shows when we look at it honestly. And what I'm about to share with you today is something I believe every adult over 70 deserves to hear before their next appointment. After a certain age, some of the most routine medical tests can quietly set off a chain of events that does more harm than the condition they were looking for ever would have. Today, I'm walking you through 5 specific screenings worth reconsidering after 70. I'll tell you what the evidence shows, I'll tell you what questions to ask, and I'll give you a framework at the end that will completely change how you walk into a doctor's office. Stay with me through all 5 because number 3 changed the way I think about cardiac care entirely. And number 5 is the one that almost no one talks about until it's already too late. Before we dive in, I'd love to know where you're watching from today. Drop your city or your country in the comments below. I read every single one, and it genuinely helps me understand who this community is and what you need from me. Let's begin. The framework, longevity lens. Before we get to the 5, I need to give you one idea. Because without it, everything else I say today is going to sound either alarming or confusing. And it's neither. I call it the age adjusted benefit calculation. Here's the simple version. When you're 50, screening medicine is one of the best investments in your health you can make. You find a slow growing problem early, you treat it, you potentially add decades of healthy, active life. The math is clean, the benefit is real. But after 70, 3 things change that math significantly. First, many conditions that routine screening finds in older adults will never actually hurt you. They grow slowly, they cause no symptoms. In many cases, you will outlive them entirely. But modern medicine doesn't have a leave it alone setting, it has a treatment setting. And once something shows up in a report, that setting turns on automatically. Second, your body's resilience to intervention is different at 74 than it was at 54. The procedure a 55-year-old recovers from in 10 days can mean 3 months of rehabilitation for a 78-year-old. It can mean complications. It can mean losing the independence you worked your entire life to maintain. Third, and this is the one I need you to really sit with, there is something called the cascade effect. One test finds a small abnormality. That triggers a follow up scan. The scan recommends a biopsy. The biopsy leads to a procedure. The procedure causes a complication. And a person who walked in feeling completely well is now navigating a medical system that was set in motion by a test they arguably never needed. That is not a horror story. That is a documented pattern in the medical literature. And it is happening to people every single day. Keep that framework in your mind as we go through each one. Checkup number 1, routine colonoscopy after 75. Let me tell you about a woman I'll call Margaret, 78 years old, former florist, sharp, funny, fiercely independent. She'd had 2 colonoscopies in her 60s, both completely clean, no polyps, no family history of colon cancer, no symptoms of any kind. But when she transferred to a new practice, her doctor saw she hadn't had a colonoscopy in 8 years and said the words that started everything. Let's just get you updated. Margaret didn't push back. She was from a generation that trusted doctors completely, and she didn't want to be seen as difficult. So she drank the prep solution the night before, the liquid that clears your bowels for the procedure. By morning, she was on the floor of her bathroom. Her daughter found her confused and barely responsive. They called an ambulance. Margaret never had the colonoscopy. She spent 5 days in the hospital instead, recovering from severe dehydration and dangerously disrupted electrolytes that had put her heart at genuine risk. And here is the part that still stays with me. She didn't need that colonoscopy. The United States Preventive Services Task Force, the organization that sets evidence based screening guidelines in this country, explicitly recommends against routine colonoscopy screening for average risk adults over the age of 75. The risks are real, and they deserve to be named. Bowel perforation, a literal tear in the colon wall, occurs in roughly 1 in every 500 colonoscopies. In a younger patient, that is a manageable surgical complication. In a 78-year-old, it can mean emergency surgery, extended hospitalization, and a recovery that permanently alters quality of life. Meanwhile, the colon cancers most likely to be found in asymptomatic older adults tend to grow so slowly that in many cases, they would never cause harm in a person's remaining lifetime. What to do instead? If you're over 75, average risk, with no symptoms and a history of clean scopes, ask your doctor about non invasive stool based testing. The Cologuard test or an annual FIT test can identify genuine warning signs without putting your body through a procedure it may not be equipped to handle. If you do have symptoms, blood in your stool, unexplained changes in bowel habits, abdominal pain, that is an entirely different conversation. Please see your doctor. Symptoms change the equation completely. Checkup number 2, aggressive cancer screening in low risk older adults. I want to be very precise here because this is a topic where nuance isn't optional, it's essential. I am not telling you to avoid cancer screening. Cancer screening has saved millions of lives, it can save yours. What I am asking you to consider is this: after 75, aggressive screening in average risk, asymptomatic individuals carries a serious overdiagnosis problem, and overdiagnosis almost always leads to overtreatment. Let me explain what overdiagnosis actually means in plain language. Imaging technology today is extraordinarily sensitive. It can detect cancers that are, biologically speaking, barely active. Tiny, slow growing tumors that, if left completely alone, would never spread, never cause a single symptom, and never shorten your life. You would die with them, not from them. But the moment the word malignancy appears in a report, the clinical system activates. Biopsies, specialist referrals, treatment decisions. All of it moves forward regardless of whether that cancer actually represents a threat to the person sitting in the exam room. Studies published in the New England Journal of Medicine found that a significant proportion of cancers detected through mammography in women over 70 were clinically insignificant, meaning treatment offered no survival benefit, only side effects, disruption, and anxiety. For men, PSA testing after 75 carries a similar pattern. A slightly elevated PSA triggers a biopsy. The biopsy finds a low grade, slow moving cancer. Treatment is recommended. And a man who is living fully, actively, independently finds himself managing the long term consequences of treating something that was never going to harm him. What to do instead? Have an honest, specific conversation with your doctor about your risk profile. If you have a family history, genetic markers, or symptoms, screen. Absolutely screen. But if you are average risk and asymptomatic, ask this question directly. If we find something, what are the realistic treatment options at my age? And would treating it actually improve or extend my life? That question alone, in my experience, changes the entire conversation. Checkup number 3, routine cardiac stress testing without symptoms. This is the one that surprised me most when I first started looking closely at the data because it sounds so responsible, so proactive. Your doctor says, "You're 73, let's just make sure your heart is doing okay." You get on a treadmill, or they give you a medication that temporarily stresses your heart while they monitor the response. It sounds like exactly the kind of thing you should be doing. Here is the problem: cardiac stress tests in people without symptoms have false positive rates that can reach 40% or higher in certain populations. That means nearly half the time, the test flags something abnormal when your heart is actually functioning just fine. But medicine cannot simply shrug at an abnormal result. That false alarm sets the next phase in motion: a a cardiac catheterization, a thin tube threaded through your blood vessels, through your wrist or groin, into your heart. Risks include bleeding, vessel injury, arrhythmia, and in rare cases, it can actually trigger the very heart attack or stroke you went in hoping to prevent. And here is where it becomes truly counterintuitive. If the catheterization finds a partial blockage, which is extremely common in adults over 70, many of whom have zero symptoms, you may be recommended a stent. The landmark ischemia trial, one of the most significant cardiac studies of the past decade, found that stenting patients with stable coronary artery disease did not reduce heart attacks or extend life compared to medication and lifestyle management alone. Read that again slowly. The stent carried real procedural risks. It required a lifetime of blood thinners with their own bleeding complications. And statistically, it did not improve outcomes compared to walking 30 minutes a day and taking a blood pressure medication. You went from feeling well to a routine test to a false alarm to a catheterization to a stent to a lifetime of blood thinners, and you are no better off than you would have been if you had just gone home. What to do instead? If you have no chest pain, no unexplained breathlessness, no dizziness during activity, talk to your doctor about optimizing your actual risk factors: blood pressure, cholesterol, blood sugar, sleep, movement. That is where the meaningful gains are, and they carry none of the procedural risk. If you're still with me and finding this valuable, drop the number 3 in the comments. It helps me know you're here, and it helps this video reach more people who need to hear it. Checkup number 4, routine DEXA scanning with automatic medication. This one takes a little more explaining because osteoporosis is real. Falls are devastating in older adults. I am not minimizing either of those things. What I am asking you to look closely at is the automatic pipeline that often follows a DEXA scan, result in patients over 75. A DEXA scan detects low bone density. A bisphosphonate is prescribed, medications like alendronate or risdronate. You take them for years, quietly assuming you are protected. Here is what frequently goes unmentioned in that appointment. Long-term bisphosphonate use has been associated with a rare but serious condition called atypical femoral fractures, spontaneous stress fractures in the thigh bone, the very bone these medications were prescribed to protect. These fractures are severe, often require surgery, and can be life-altering. They are also associated with osteonecrosis of the jaw, bone deterioration that is painful and notoriously difficult to treat. Now, here is what the evidence consistently shows about fracture prevention in older adults. The single most effective intervention is not a medication, it is fall prevention. Balance training, specifically Tai Chi, has been shown in multiple studies to reduce fall risk by nearly 50%, removing tripping hazards from the home, installing grab bars in the bathroom, having vision checked regularly, reviewing medications for side effects that cause dizziness, ensuring adequate protein and vitamin D intake. These interventions reduce fracture risk more meaningfully than bisphosphonates, with no side effects, no cost, and genuine improvements to overall strength and coordination. There are absolutely patients who need medication for bone health, those who have already had fractures, those with very low T scores, those with specific clinical risk factors. I am not speaking to them here. I am speaking to the active, asymptomatic 74-year-old who has never broken a bone, who gets a routine DEXA, and is handed a prescription before anyone has discussed alternatives. What to ask your doctor. Before we talk about medication, can we review my actual fall risk factors and compare the fracture reduction from this drug against a structured balance and strength program? Checkup DER 5, asymptomatic carotid artery ultrasound screening. This is the one almost no one is talking about. And based on what the research shows, it may be the most consequential conversation we are not having. A carotid artery ultrasound checks the large blood vessels in your neck that carry blood to your brain. The logic is intuitive. If we find a significant blockage, we can surgically address it and reduce your stroke risk. It sounds like exactly the kind of preventive medicine we should be doing. The reality is far more complicated, and for people with no symptoms, far more dangerous than it appears. Here's the central fact: the surgery used to treat a carotid blockage, called a carotid endarterectomy, carries a 2 to 3% risk of causing a stroke during or immediately after the procedure. In older adults with additional health conditions, that risk is higher. The United States Preventive Services Task Force explicitly recommends against routine carotid artery screening in adults who have no symptoms, no mini strokes, no sudden vision changes, no neurological episodes. Their analysis found that in asymptomatic individuals, the risk of surgical harm outweighs the potential benefit. Here is why. Many adults over 70 have some degree of narrowing in their carotid arteries. That narrowing has often been stable for years, silent, not causing any problems whatsoever. When you screen for it routinely, you find it. And then a well meaning, well trained surgeon recommends repairing it. But the surgery to repair a blockage that was never causing symptoms can, and sometimes does, dislodge a small piece of plaque that travels directly to the brain. The documented outcomes in the medical literature are sobering. People walking into a routine screening appointment and leaving on a fundamentally different trajectory, not because of the blockage that was found, but because of the intervention that followed it. What to do instead? If you have no symptoms of stroke or TIA, no sudden vision loss, no facial drooping, no arm weakness, no severe sudden headache, routine carotid ultrasound is not recommended by the evidence. The better investment is in controlling the modifiable risk factors that actually drive stroke: blood pressure, first and foremost, blood sugar, smoking cessation, atrial fibrillation management, and consistent physical activity. If you do experience any neurological symptoms, even brief ones that fully resolved, please seek evaluation immediately. Symptoms change everything. Closing framework: the 5 questions. I promised you something practical. Here it is. The next time your doctor recommends a screening test, especially if you are over 70 and you are feeling well, I want you to have 5 questions ready. Write them down, put them in your phone, bring them to every appointment. Question 1: what is the false positive rate of this test for someone my age? This tells you how likely the test is to set off a chain of unnecessary follow up procedures, even when nothing is actually wrong. Question 2: if this test finds something, what are the realistic treatment options for someone my age and health status? This moves the conversation from findings to outcomes, from what we might discover to what we would actually do about it. Question 3: what is the procedural risk of any treatment we would likely pursue? Every procedure carries risk. You deserve to know what that risk is before you agree to the test that might lead there. Question 4: what happens if we monitor this rather than treat it immediately? For many conditions found in older adults, watchful waiting is a legitimate, evidence supported option. Make sure it's on the table. Question 5: what is the most effective non invasive approach for this condition? Because very often, as we've seen today, lifestyle management and medication outperform procedural intervention, with far less risk and far better quality of life. Any good physician will welcome these questions. They will respect you more for asking them. And if a doctor makes you feel difficult or dismissive for raising them, that is meaningful information about whether that physician is truly the right partner for your care. Close. I want to leave you with something I genuinely believe. There is a difference between medicine that finds things and medicine that helps you live well. After 70, the purpose of your healthcare should not be to generate findings. It should be to protect your quality of life, your independence, your energy, your ability to be present for the people and the moments that matter most to you. The wisest physicians I have ever known understand that recommending watchful waiting sometimes requires more courage than ordering another scan, that doing less with full knowledge and clear intention can be the most sophisticated medical decision in the room. You have the right to know what any test is looking for. You have the right to know what happens if something is found. You have the right to ask whether that finding would actually be treated and whether that treatment would genuinely improve your life. Medicine has given us extraordinary tools, but a tool is only as valuable as the judgment behind its use. And you deserve a healthcare experience built around your goals, your values, and your body, not around a protocol that was designed for someone 30 years younger. If this gave you a new way to think about your health, please subscribe. I release new videos every week, evidence based, honest, and always written with you specifically in mind. And please leave a comment below. Have you ever had a routine test that led somewhere you didn't expect? Your story might be exactly what someone else needs to read before they walk into their next appointment. Take good care of yourselves. I'll see you in the next one.